Welcome everyone, and sorry we're starting just a few minutes late. Thanks for joining us today for Pediatric Seating. My name is Michelle Lange. I'm an occupational therapist in the Denver, Colorado area, and I do quite a bit of pediatric work. So this is what we will be covering today. Unfortunately, my internet decided to be uncooperative 2 minutes ago, which is not a good time. So Deb is going to help me out by advancing our slides. So if you can advance the slide to Deb, and then I'll just say next slide after that. So when we look at pediatric seating, we need to keep in mind what is different versus seating adults. When we're talking about positioning, we're talking about positioning within a mobility base, and so quite a bit of the seating is going to be dependent upon the mobility base itself, and we'll see that as we go through this content. Another factor that, of course, is different is growth. Kids are growing, and so these frames need to accommodate quite a bit of growth. Kids can have quite rapid growth spurts, and because of funding limitations, we often are unable to replace their equipment as quickly as we need to. Now, with that said, even if a funding source says a certain base needs to last a certain amount of years, those are basically a guideline, and if an exceptional amount of growth occurs during that time, often exceptions are made and we can acquire new equipment. Other changes need to be accommodated as well. Many children are going through active tone management. We'll discuss that in more detail in just a moment. That needs to be accommodated as it impacts the positioning of the client. Some of our younger clients have progressive conditions such as spinal muscular atrophy or Duchenne's muscular dystrophy. And as the child grows, we could see a change in range of motion and orthopedic changes that need to be accommodated within the seating system as well. So those are all things that vary compared to the adult population. Next slide. Now, when we're looking at pediatric seating systems and the mobility bases that support them, we need to keep in mind the size of each. Some of these seating systems and mobility bases start very, very small, even accommodating children that are just being discharged from a neonatal intensive care unit. So newborn size all the way through adult size. If you have children of your own, you know that sometimes those kids can reach adult size even in their early teens. And we have to keep in mind the available growth in the seating system itself as well as in the mobility base, because each may have a different amount of seating. It is very common to replace the seating system while using the same mobility base. The mobility base often has more growth available in it than the seating system itself. Next slide. So we need to be flexible to accommodate a variety of changes in the medical condition. So children that have progressive conditions, as I mentioned before, such as spinal muscular atrophy, will often experience a progressive weakness. This is going to mean that it's harder for the client to maintain a seated position, as well as more difficult to use their body functionally, access their technology. That progressive weakness means that the seating system needs to provide perhaps more and more increasing support as the client's needs change. Children often experience various surgical procedures, and these can include orthopedic procedures, anything from hip surgeries such as osteotomies to muscle releases to injections. This kind of gets into tone management as well. Child might even have a spinal fusion during the teen years. Many children who are having difficulty with their feeding may also have a gastrostomy, a G-tube or G-button inserted. This can lead to a rapid weight change, which is certainly the intention of that intervention. But a child might gain 5-10 pounds after a surgery such as that, and for a small child, that can be a significant percentage of their body weight and impact the seating system and the fit. Tone management includes oral medications, baclofen pumps, injections such as Botox and phenol to muscles, and this again impacts posture and the amount of support that's required. And then finally, orthopedic changes. Unfortunately, when children grow quickly and muscles perhaps are tight in children with increased tone, this can be conditions such as cerebral palsy or traumatic brain injury, the bones which are growing respond to those tight muscles, and unfortunately those bones can rotate or otherwise change, and we have orthopedic changes to the spine as a result of the rib cage or to the hips, and these can lead to situations that need to be addressed in the seating system as well. Next slide. The seating system and mobility base need to be flexible to accommodate the environment that the child's in as well. So younger children in particular tend to be mostly at home. Otherwise, perhaps they're out in the community or going to various appointments. As children get a little older, they could be bringing this mobility base to a daycare or preschool setting, and then eventually elementary school and beyond. Each of those environments have different requirements, and so the base and seating system need to meet those needs, and certainly the needs out in the community as well. Next slide. So mobility bases are categorized by dependent and independent mobility, and the seating that's available on each of these bases is quite varied, and this is something that's rather unique to the pediatric population. When we're looking at adult seating systems, oftentimes we can use just about any seating system that meets the client's needs, but that's not always the case with these pediatric options. So under dependent mobility, we have something that's sometimes referred to as a dependent mobility base, also known as adaptive strollers. These have often seating included with them. Then we have manual chairs that are designed for the caregiver to propel. In independent mobility, we have manual wheelchairs that are designed for self-propulsion and power wheelchairs. Next slide. So let's start by discussing adaptive strollers. In adaptive strollers, we have pros and cons that we need to keep in mind, and that's important for us in making our determinations and matching client needs. Adaptive strollers work well for very young, very small children. These are what are used for children that are perhaps just being discharged from that neonatal intensive care unit. There's lots of features to support that very young child who often has a lot of medical needs at that point. So for example, these frames can include tilt, recline. The child can be turned, the entire seating system can be turned on the base so that the child can face the caregiver. This allows the caregiver to more closely monitor the child's position and their medical condition. There's also supports on the frame for oxygen and vent support, because some of these children can have that medical equipment, and it's important that this can be mounted to the base. Families often more readily accept a stroller. It looks more typical for a child of that age. These also tend to be rather lightweight and easy to fold. That's important because when we're talking about a very young child, the family may not have yet had any opportunity to explore accessibility in terms of the vehicle. Also, young children are in a car seat. Any child should be in a car seat until about 40 pounds. This means that they're not yet riding in their seating system within the vehicle. The vehicle doesn't have to have the same level of accessibility, but the stroller or other mobility base does need to be transported, and so we got to make sure that that can fold and easily be stowed away. Next slide. Strollers, however, often do not have a lot of seating options. It really varies. Some have quite a bit of support and some have very little, like the one pictured here, which is basically a large umbrella stroller. Often these place the child in a fixed posterior tilt. So you can see in this picture that the client is tipped back a little bit. That helps the client to stay upright and not fall forward into trunk flexion, but it's also not a very functional position. These are designed for dependent mobility, not for someone to self-propel. And if the client's using other technologies such as a speech generating device, a tablet, these can be difficult to mount to the frame for a couple reasons. The frame is not very strong, and it's because it's designed to be lightweight and easy to fold. And so some mounts, if we really crank down on that frame, can actually distort the tubing. The tubing is also not a typical size in relation to or in comparison to manual wheelchairs, and so it doesn't always fit with standard mounting systems. Some strollers do not have a lot of growth or adjustment to the frame. Growth is important in allowing this to last for a while and meet the client's needs, but frame adjustment is important to meet someone's positional needs. Next slide. So what seating is available on these adaptive strollers? Well, we have a couple different options. Sling seating is very common. It allows this to fold quite easily, but it doesn't provide very much postural support for the client. Sling seats, or these umbrella-style strollers, often have a seat depth that's very short in comparison to the back height. Part of the reason for that is the back also supports the back of the head. That may not be always the best position for the client. Next slide. Other seating options that are available on adaptive strollers include some offered seating by that particular manufacturer. So this is going to vary by brand of stroller. There's a variety of supports that may be available. These don't tend to be very aggressive or adjustable, so we just have to make sure it's adequate for the client's positional needs. A few of these companies offer some solid seating surfaces, like the blue one you see pictured here. These need to be removed in order for this to fold. Next slide. And then we have aftermarket seating. So this can open up a whole variety of seating options, including linear seating systems and contoured seating systems. But these strollers aren't designed to support these very well, and so sometimes this doesn't work out as well for the child. Next slide. The seat-to-back angle adjustment is an important adjustment in seating. In this picture here, the seat-to-back angle is quite closed. Sometimes a closed seat-to-back angle can help the child to stay in their seating system, but it's difficult to maintain an upright posture under these circumstances. So the seat-to-back angle might be fixed where it's non-adjustable. It might be adjustable only by tool or very easily adjustable, such as by a knob, to open that seat-to-back angle, provide more of a position of rest for the client. Next slide. Some strollers also include a tilt adjustment. By tilting the client rearward, this can help to manage fatigue. It can help to optimize postural control if the client is having difficulty sitting up against gravity. Some clients will eat better with some tilt provided, and that might be either eating by mouth or even doing a tube feed. And by using a tilt, this can help address certain medical needs, including if a client has just had a seizure and perhaps has that phase after a seizure where the client is quite fatigued, and this will allow for that position of rest. Next slide. Recline is available for the same purpose. This can also address fatigue, postural control, feeding, medical issues. In this case, the seat-to-back angle is opened up. The challenge with recline for a lot of children is then when the recline is reduced, bringing the client back up to a seated posture, the pelvis tends to get pushed forward and the client might lose their position. Tilt and recline are sometimes used for even our very youngest clients, because if a child, even an infant, does not yet have the ability to sit upright at all, most children don't sit until 6, 7, 8 months of age independently. Even a typical child, that child is going to need to be tilted or reclined to accommodate for that. Many of our clients that we work with do not achieve independent seating and still need that additional support. Next slide. Transportation is also important. Many of these bases, as I mentioned, full because the client may not have an accessible vehicle yet. And if they're not in school yet, they're not going back and forth on a school bus. Again, those young kids are safer in a car seat. They're not going to be riding in these bases yet, though a lot of these bases do have a transit option, which allows these to be used with tie downs. And that's important to keep in mind even with our younger clients because these tie downs may be used in the future. The school bus, even with very young children, will often transport children within their base, or they may choose to tie down the base, take the child out and transfer them into a separate car seat. That way the base is not a movable object within the bus or the vehicle, it is secured. Next slide. Growth, very important in these strollers. Very young children grow a lot. And these dependent mobility bases or strollers have to accommodate a lot of growth. Unfortunately, they're very easy to outgrow, as often less growth is accommodated than in a manual wheelchair. This is an important consideration when we're trying to determine whether a child who's maybe 4 or 5 years old should be in a stroller or a manual wheelchair. Next slide. There are medical considerations as well, and these are really important for those newborns or infants that have a lot of medical issues. Again, there's options to support oxygen holders, vent trays, even an IV pole. I see quite a bit of children that are pretty much on a continuous drip feed with their G-tube because they're having difficulty receiving a larger feed or bolus feed. And so it's important that this be attached. And these strollers do allow often time for the child to face the caregiver so they can be monitored if there's a lot of medical needs. Next slide. There's some other options that are available on these particular strollers. It varies by manufacturer. Some of these offer a high-low base, and that's pictured here on the left. This high-low base allows the client to be positioned at a higher height for activities like perhaps being at a tabletop at school, being at the dining room table for feeding, but then at a lower level for play. AutoBlock has a tandem option, and this can be important when we're dealing with twins. I've actually dealt with quite a bit of twins over the years where one or both twins has a disability. Twins are often born early, and sometimes one or both twins may have a condition such as cerebral palsy. This allows for those children to be transported together. Next slide. And here's a list of some examples of adaptive strollers that are available on the market right now. If you have an opportunity to participate in a seating evaluation, it's important to work closely with the supplier, with that evaluation team, very key person who is very familiar with all the ins and outs of these options as well as funding. Next slide. So next we're going to look at manual wheelchairs that are designed for dependent mobility. So someone else other than the child is going to be propelling this chair. It might be that the client is simply not capable motor-wise of operating this manual chair. Seating options that are available on this category of chair include sling seating, linear, contoured, and a variety of off-the-shelf cushions and backs. Next slide. Now, sling seating is not a common option on pediatric-sized manual wheelchairs. It's more common on adult-sized chairs. It's not something that provides very much support, whether you're a child or adult, and so is not really a good option. Next slide. But we do have other options. There's a number of off-the-shelf cushions that are available out there that come in pediatric sizes. There's linear seats, which primarily have flat surfaces, and these accommodate quite a bit of growth, and we can add on a variety of anterior and lateral supports in combination with those flat surfaces. And then there's contoured surfaces, either generic contours or something that's actually molded to the client's body if that's what is required. Next slide. Thank you, Deb. I hope I'm keeping up with you okay. Then we have the seat to back angle adjustment. Now, this is a really important adjustment for positioning. It's something available on the frame. It's sometimes available on adaptive strollers, not always, but usually on these dependent manual wheelchairs. Very important as this dictates the amount of seat to back angle for an individual client that matches their postural support needs as well as the range of motion at the hip. This isn't as critical if someone's using a one-piece seating system. Some contoured molded systems are one piece, but this still does need to be mounted and the angle might need to be adjusted to match the angle of the one-piece seating system. Next slide. Tilt adjustments are available. This helps, as it does with adaptive strollers, to optimize positioning, particularly head and trunk control, helps with managing fatigue, and a variety of medical issues, including those post-seizure times. This can also help with functional tests, particularly feeding and vision. Next slide. Recline also addresses these issues, but recline is not an option that's commonly seen on this category of wheelchairs. It's not very common in pediatrics. Most pediatric reclining chairs offer very little seating and are designed for post-operative use only. So let's say this client that we're working with has had hip surgery, perhaps a VDRO, and now is in a spica cast. They may not sit in their wheelchair, but they might have a recliner chair for a period of time and then return to their own chair. Next slide. The knee angle of the frame is something that's important to keep in mind as well. Kids are often placed at a 90-degree angle at the knee. This is not a problem with children because they have shorter legs. 90-degree angle is not as common with adults because as our legs are longer, that foot plate is going to occupy the same spot as those front casters, and that can cause difficulty with turning the chair because the caster is going to keep running into the foot plate. Children might need those knees flexed at about 90 degrees because oftentimes the hamstrings are tight, particularly in kids who have increased tone. And that means that an angle at the knee that is further out away from the chair is going to put those hamstrings on stretch. Next slide. Folding is very important still because these are still at times young children. Perhaps the family does not have an accessible vehicle. Even if this folds, the frame is probably going to be heavier than those adaptive strollers, and the seat often is going to have to be removed. So if the client has a seat that accommodates their needs, that has to come off, allow some folding of the chair either side to side, or in this case, in this picture, the back canes fold down. We end up with somewhat of a box shape, and this can be placed in the trunk. The rear wheels can often be removed as well. And the child, until 40 pounds, may still not be riding in the wheelchair. Next slide. Stroller handles are a unique feature on pediatric chairs, particularly these dependent manual wheelchairs. This allows a caregiver to push the chair for the client. Pediatric frames are short and caregivers might be much taller, so this is easier to push for the client, particularly if that chair is tilted, because now those push handles are even lower in the tilted or reclined position. Some of these stroller handles are angle adjustable, and that can be really handy when dad is 6'2" and mom is 5'0". Sometimes the stroller handles are removable too to allow the system to be folded. Next slide. Many of these frames are crash tested and have an attachment point or transit option that allows for attachment of tie downs. This is for the client who rides in the chair at any time, including that school bus. And if we think this could occur during the lifetime of the chair, it's important to add on this feature. School buses certainly require this option if they're going to transport the child. Next slide. These chairs, dependent mobility manual wheelchairs, include a lot of growth because a lot of growth is anticipated during the lifetime of the chair. Many of the children who require manual wheelchairs have a lot more linear growth in length, than they do growth in width. If that was only the case for us adults, adults tend to grow more in width because we're done with that linear growth. So seat depth and back height are more important than the actual seat width growth amount. Next slide. On this slide here, you'll see a video, and this is showing, and we don't need any audio on the video if that's something you can control, Deb, because there's actually a lot of background.
Oh, wow, that's really go. How many degrees does that go?
There's a lot of dynamic seating options that are available that allow the client to move within their wheelchair. This movement can achieve several goals. A lot of people, including you and I, need to move. Our clients might need to move in order to tolerate their seating system well. Next slide. Dynamic seating can also absorb extensor tone. So clients who are really extending forcefully in their seating system, this can absorb that tone, diffusing that tone, relaxing that tone, as well as protecting the wheelchair from breakage. Some children are very capable of breaking components clean off their chair. So there are dynamic backs, footrest hangers, and headrests available, and these can often be retrofitted to these chairs. They do add to the weight of the chair and are more commonly seen on manual chairs and even power chairs where the client is not self-propelling. Next slide. And when we get to our next category, I'll take a quick break and see if we have any questions. So other frame considerations on these dependent mobility manual chairs include features such as vent trays and oxygen holders for clients who may need those, and change in seat to floor height. That is the height from the seat pan, the bottom of the seating system, to the floor. These seat to floor heights are very important with children for a couple reasons. Children might need to be positioned in front of a very small desk, let's say in kindergarten, first grade, and then go to a higher desk later on. Also, even though this child is not self-propelling, the child might be working on transfers, and the height that they are coming up from on the wheelchair is very critical to helping with those assisted transfers. And our next slide shows a few examples of companies that make these dependent manual wheelchairs. All right, so before we discuss some seating implications of manual wheelchairs that are designed for self-propulsion, do we have any questions at this point? Deb, do we have any questions?
I'm not seeing any right now.
Oh, okay. If any come in, just let me know, and I'll take another break again in a few minutes, and we'll check that out. Okay, so now we're going to move on to independent mobility with manual chairs. These chairs are designed for self-propulsion. And we're going to start with the advantages or pros of those chairs. So there's a lot of different options in terms of the mobility bases in this category. And these chairs tend to include lots of frame adjustment, lots of growth, a variety of seating options, features such as tilt, recline, elevating leg rest, and even standing features, and some are crash tested. Next slide. Some of these, however, are not crash tested, and that's really important to keep in mind for kids that are in school because they may not be able to take this chair onto the bus. Some of these chairs that are designed for self-propulsion are in a category called ultra lightweight chairs. They're very, very lightweight in order to optimize self-propulsion, but sometimes funding can be more difficult for these chairs. We have to be mindful of potential caster footplate interference on some of these chairs. We'll go through that. And children who are self-propelling are at risk for repetitive stress injuries. So it's important that we keep in mind proper instruction on self-propulsion to optimize efficiency in self-propulsion, but also to reduce chance of shoulder and wrist injuries. You know, when we're providing self-propulsion to a young child, that child could be propelling for decades. And even if they're not at risk for repetitive stress injuries now, they certainly are in the future. It's almost unavoidable, and it's important that we keep that in mind and start off with as optimal a setup as we can.
Michelle, we do have a question.
Oh, yes. Oh, all right.
Sarah asks if you have any suggestions for coverage on the adaptive strollers. She says Arkansas Medicaid will deny anything that even remotely looks like a stroller.
That's unfortunate. Well, I would suggest that you start with talking with your suppliers that you're working with, particularly a supplier that knows pediatrics, knows complex rehab equipment, and ask them if together you can determine exactly what the Arkansas Medicaid coverage is. If you can find that in writing, sometimes that can be difficult, but I guarantee you it's in writing somewhere, and see what it says. If it says we do not cover strollers, or if there's certain specifics about that, because they're not allowed to deny something simply on appearance. It has to be more specific, and it's going to be in writing somewhere. From there, depending on the size of the children, there's many manual wheelchairs that can still meet that child's needs. It just may not be within the client's or caregiver's preference. But for our very small children and in certain situations, no manual chair is going to do, not for someone who's an infant. And those stroller options need to be available. So important to see what the wording is. And oftentimes it is possible to meet with those folks, discuss the policy, discuss the limitations of the policy. If that doesn't get anywhere and you have a client that really needs that equipment, then under Medicaid, there's always an option for appeal. If the family is willing to go through the appeal process, the advantage of that is it often brings to light bad policy like this. Because chances are, if it gets as far as a judge, which it very, very rarely does, Medicaid will usually say fine, but if it gets in front of a judge, any judge who is looking at an extremely small child who needs seating and a mobility base is going to say, what's the problem here? And Medicaid will, and Medicaid knows that in those situations they almost always lose. The advantage of it going that far is that it, again, brings light on bad policy and can sometimes change that. So those are my generic suggestions, and I'm sorry that's the case. It is not usually the case. Okay. So let me see if I remember where I was here. Oh, yes. So repetitive stress injuries we talked about. Keep in mind, too, that for anyone propelling a manual wheelchair can be very time-consuming and tiring to propel for long distances or over varied terrain. The world is not made up of level linoleum. For children, that can be even more so the case. So kids often propel for shorter distances. If they have to go longer distances, a caregiver often takes over. And so those push handles are still very important. Next slide. So what are our seating options on these manual chairs designed for self-propulsion? Again, we have sling seating and other options, including linear, contoured, and cushions. Next slide. Sling seating is not a common option on these self-propelling chairs. You might see it on some of the chairs that fold side to side, but does not provide a lot of support. Is really not an appropriate option for almost any of our clients. Next slide. There are other seating options, and these options are pretty similar to what's available on our dependent manual wheelchairs. Next slide. So what's different? When we're looking at a chair that's designed for self-propulsion versus a chair that's designed for a caregiver to push, what's different? Well, the seating angles may change for a self-propeller because this is a different sort of task. Instead of the client perhaps being in more of a position of rest, this client needs to be in a position that optimizes their ability to self-propel and gives them a lot of stability. So two specific features that we might see are dump and increased knee flexion. Dump means that the back of the seat itself might be lower than the front. In general, the seat to back angle might be a little closed, and that's to stabilize the pelvis. This is most commonly seen in adults who have a spinal cord injury and are paraplegic, that level of injury, because that tremendous stability is required there to optimize self-propulsion. There's some drawbacks to that position too, particularly a client losing range of motion in the hips, and so not always used as much in pediatrics. The knees are going to be probably closer to 90 degrees, if not even a little less, to also optimize self-propulsion and overall stability. The back height might be lower, and this all depends on how much trunk support is required for this individual. But in a child who is self-propelling, if the back height is below the scapulas, this allows the client to get their arms behind them, to get their hands well back on the wheel for a nice long stroke. Of course, depends on the age of the child and how long those arms are. Sometimes a back called an I or a T back may be used. If the client needs lateral support, this allows that hardware to get in closer to the body, be a little more out of the way of those arms as they're moving through that self-propulsion stroke. If we're ordering a really lightweight frame to help this client to self-propel, the seat needs to be lightweight too. If we put a really heavy, clunky seat on this, then we're wasting our money on this lightweight chair. I remember seeing a little boy one day whose seating system weighed as much as he did. Now, he was a little boy, but for him to push the base, the seat himself was very difficult. By placing him into a much lighter weight chair and seating system, he was able to self-propel, where before he could barely move the chair. So weight is a big deal. Imagine trying to push a chair that weighed as much as you do. Next slide. The seat to back angle adjustment, important to optimize positioning for the client. It's also important to support self-propulsion. Usually a little more closed seat to back angle is going to be indicated for someone who's self-propelling. Next slide. Tilt and recline are not common in these self-propelled chairs because this tilt or recline is going to move the client away from an optimal position for self-propulsion. It's going to move them away from that pushing chair. Also adds a lot of weight to the chair. There is a chair on the market, the PDG Stellar. It's very heavy. It's designed more for adult use, but it has a unique tilt where the tilt actually comes down, sinks down into the frame so that the client stays in relative position with the rear wheel. This does allow some self-propulsion, but this is a heavy frame, and so that's still difficult. Next slide. Most pediatric chairs that are designed for self-propulsion have a 90-degree footrest hanger. Those shoulder legs mean that caster interference isn't as much of an issue and helps with those tight hamstrings. Next slide. Now, these pediatric self-propelling chairs come in folding and rigid chairs. Rigid is more efficient because as you're pushing those rear wheels, most of the force is going to result in forward movement of the chair. Whereas if you have those cross braces underneath the seat that allow the chair to fold, some of that force that's going into pushing the wheels is going to create a little bit of wiggle in those cross braces and result in less of the force moving the chair forward. And so it's not quite as efficient. Rigid frames also usually mean that there's not as much growth in the frame. Often the entire bulk of the frame, not the armrest or the seating system or the footrest hanger, but the core of the frame itself often has to be replaced to address growth. Because funding is such a challenge, often there's a free growth kit at least one time so that funding doesn't have to be acquired for that time. Rigid might be harder for families to transport. Depends. Often the back will fold down on top of that frame. We end up with a box instead of the side-to-side fold, and the rear wheels can be removed. So this is often something that can be still transported. Next slide. Stroller handles add weight, and even though this makes pushing the chair easier for caregivers, stroller handles are sometimes not used on these chairs because of not adding that additional weight. If the caregivers are still helping a lot, particularly with those longer distances, it might be something that they would like to add. It's important. Next slide. It's important to keep in mind for transportation if the wheelchair has been crash tested and has tie-down attachment points. This is less common in chairs designed for self-propulsion. But in pediatric chairs designed for self-propulsion, transit options are usually still available. We have to keep in mind, too, the type of seat that the client is in because the frame itself has often been crash tested, but not with the seating system that is being used in that chair. And so important to talk to the supplier or even the manufacturer's representative about the implications of the recommended seating system within that mobility base. Next slide. These frames vary quite a bit in growth. Again, kids often need more linear growth than width. Some of these chairs have a very low seat-to-floor height, such as the Quickie Kids, for example. And those are designed to be used at those little low tables and desks, such as kindergarten level. That can help for those few years where clients have very low work surfaces and can help with transfers at that time. But these sometimes offer less growth, and pretty soon that client is sitting at a higher table with their forehead at the edge of the work surface, and that can be a problem. So these are all things that have to be considered during recommendation. Next slide. Other frame considerations include an adjustable axle. This is a common frame option that's available on these self-propelling chairs because it allows for optimal wheel placement for self-propulsion. Some chairs, such as the one pictured here, the GS, offer some specific wheel configurations where that larger wheel that's typically a little behind the client is actually in front of the client. And this is to accommodate those really short arms. There's specific wheelchair propulsion patterns that are advocated for optimal propulsion and for reducing risk of repetitive stress injuries. But they don't always work well with very small children. Small children tend to use a very short stroke because of their very short arms. And so sometimes by placing this wheel in the front, this can optimize self-propulsion for a while. As a child grows, the wheel can be placed to the rear position again. And this is available on the Quickie GS and the Quickie Kids. Seat to floor height can be determined by frame adjustments as well. This is helpful for optimizing transfers and allowing for various work surfaces to be accessed. This is something that requires quite a bit of adjustments and tools. It's not something you're going to readily do throughout your day, but you can choose the optimal seat to floor height, and sometimes this can be modified as a child grows. Next slide. And these are some examples of manufacturers that make manual wheelchairs designed for self-propulsion. All right, Deb, do we have any questions at this point?
Right now I don't see any questions in the chat box.
Okay. Feel free to go ahead and put those questions in, and we'll get to them as we move along or at the end of the session here. All right, our next category of chairs are manual wheelchairs that are sometimes called a performance chair. In the adult world, particularly when we're dealing with Medicare, which is a very different funding beast, these are sometimes referred to as ultralight chairs, but some of those ultralight chairs in the pediatric world can fall into either of these categories. One adjustment that's available on these higher performance chairs is that the seat to back angle adjustment tends to be even more closed, because these are children that often require less postural support and are better at self-propulsion. So we have chairs that are designed for self-propulsion but still support a child who needs a lot of postural help. And then there's performance chairs, which are for children that have an easier time with self-propulsion and do not require as much postural support. Next slide. Tilt and recline adjustments are not an option at all on performance chairs. The client's going to need another means of shifting their weight, another means of dealing with, I'm tired and I just need to rest. Next slide. Sometimes the feet are actually placed behind the knees in these frames. This again is designed to optimize self-propulsion and prevent caster interference. But this can lead to the hamstrings getting even tighter, and that's something we need to keep in mind. We can place the knees at 90 degrees in these performance chairs. That can still optimize self-propulsion, less risk of those range losses. And caster interference isn't usually an issue as long as the child's lower leg length isn't long enough for those foot plates to be in contact with the casters. Next slide. We can get these performance chairs in a folding or rigid base. Again, rigid tends to be more efficient for self-propulsion, but does mean less growth, and sometimes this can be a little more difficult to transport. Next slide. Less of these frames are crash tested and have a tie-down attachment point. The reason is, the assumption is that a client who can use a performance level manual wheelchair is more functional, doesn't need as much postural support, and is more likely to be able to transfer out of the chair and sit in a standard vehicle seat. And that's why a lot of these don't have that option. So this is something, again, that's very important during the assessment to consider is, do we need to get into this performance level chair or not? Will these considerations be a problem for an individual child? Next slide. We have to keep in mind growth. These performance level chairs generally don't offer as much growth as either the dependent manual chairs or self-propelling. They provide, part of the reason for that is chairs that provide a lot of growth offer adjustments to the frame that add weight to the frame. And the goal is to reduce that weight as much as possible to optimize self-propulsion. And so as a result, there's not as much of that adjustment. Often the entire frame has to be replaced. This is not as common on pediatric performance chairs. There's not as many of these pediatric chairs as there are adult performance chairs or adult ultra lightweight chairs because of this growth challenge. Next slide. Other frame considerations to keep in mind are the ability to dump the seat, lower the back of the seat in relation to the front of the seat, to camber the wheels where the wheels are angled out a bit, and other adjustments to the center of gravity of the chair. The center of gravity of the chair is important to perform maneuvers such as wheelies, to get up and over a curb, for example, but still have a chair that's not overly tippy. So center of gravity could easily change over the years as the client gains more manual mobility skills. New manual wheelchair drivers often have a chair that's a little less tippy. It makes it hard, if not impossible, to do a wheelie or to maneuver this chair quite as well, but it makes it safer for a smaller child. And then there's other options to reduce weight. It's all about that weight. That even gets down to the style of the wheel itself. Mag wheels are often used with children as opposed to spokes, but these weigh more. Airless inserts in wheels can increase the weight, but it means now there's less maintenance for the family, and we don't have to deal with flat tires. Pneumatic tires are going to reduce the weight of the chair, however. Next slide. And here's some examples of manufacturers who make these pediatric performance chairs. All right, we just have a couple more slides here, and then I'll go ahead and take any questions. So if you have any, feel free to start typing those into the box. Our next slide shows power mobility. Seating on a power wheelchair is usually fairly straightforward. Sling seating is generally not available, which is fine. Most people who need a power wheelchair require more postural support than sling seating affords. Cushions, linear seating systems, molded seating systems can all easily be accommodated on a pediatric power wheelchair. The seat to back angle is usually adjustable, and either manual or power tilt and recline options are available on many pediatric chairs. Not all of them, but many of them have those as options if that's what the client needs. Next slide. So what's important to remember? Well, seating for kids needs to be very flexible to accommodate change in growth, medical status, orthopedic changes, etc. Children aren't just small adults. When pediatric chairs first became available, they were basically an adult chair that had been cut down and chopped up. But our pediatric chairs now are really built from the ground up to meet kids' unique needs. Family goals are very important too when we're dealing with children. We're not just talking about our goals or the goals we perceive for the client. It's recommending something that will work for the family as well. I often try to remind myself that I don't have to take home this equipment that I've recommended, the family does. They have to live with it, and I have to make sure it meets their needs. Next slide. Okay, so let's see if anyone has any questions. If you're still typing, don't worry, we will wait for you.
Michelle, we have a question. Lynn is asking, how do you successfully stabilize the pelvis in a dependent wheelchair for a child who has strong continuous extensor tone without causing skin shear?
Right, that's a great question, and I'm sorry we didn't have time to really address that today. But we can, boy, it's kind of a big topic. I often present just on how to position that pelvis, and that can take an hour to address. But very much in general, for someone who has a lot of tone, that pelvis keeps going forward into that posterior tilt. A couple things you can do. First is looking at the angle of the hip belt, the pelvic positioning belt. Usually an angle of about 60 degrees is going to work well. A lot of pediatric belts are placed more at 45 degrees, and that lets the pelvis rotate right underneath it. So I would check the angle of placement, and that's something the supplier can help you change if needed. The other thing you can change is look at the seating surface itself. With children, a common seating strategy that's used in that scenario is something called an anti-thrust seat. So you can ask the supplier about that as well. But there's a curb towards the front of the seat that's placed just in front of the ischial tuberosities. So if the client extends, it blocks those ITs from moving up and over the curb. And then the final strategy you might want to keep in mind is dynamic seating. If you can use a dynamic back to absorb some of those extensor forces, that can be helpful too. And one dynamic back that works on a lot of different pediatric bases, because chances are this client already has a pediatric base, is from Seating Dynamics, and it's their rocker back. So you might want to check that out. I hope that helps. Do we have any other questions?
Lynn is asking if you have success with a sebaceous bar.
I use sebaceous bar sometimes with clients to keep that pelvis back. I try not to use it if I can make other strategies work, only because if that bar is not positioned absolutely perfectly, and that means needing to be changed as the child grows, it either will not work or it can sometimes cause harm to the client. And if the caregivers are not really, really careful. I've had one client in particular who had a very bad wound created by someone not putting on the sedacious bar appropriately.
I don't see any other questions at this time, Michelle.
Okay. Well, we can wait a minute to see if anyone has any other questions. If you want, you can go to the next slide where I just say thank you very much, because I do appreciate everyone's time when it comes to busy schedules and summertime and looking at this. If you want more information on dynamic seating, I did a webinar with ABLEnet just last month on dynamic seating on June 28th. And you can get that in the recorded library of webinars if that's something that is of interest. And
Michelle, I have another question from Douglas.
Sure.
He is asking how to make the decision between power and manual, and how to help parents consider both options when both are reasonable.
Well, that's another big question. And probably the best thing would be to refer you to some other webinars that I've done in the past for ABLEnet. If you go back to those recorded webinars and look in there for some that I've done. We've had some webinars where we've talked about power mobility with kids. Of course, in general, it's important to make sure that there's not a way of meeting the client's mobility needs through manual mobility. If you're working with a client who cannot self-propel or cannot self-propel efficiently, then power mobility is indicated. Not all families are really keen on that, but one thing that helps is to find that common denominator, that common ground. And usually what everyone can agree on is that we want this child to be as mobile as possible. And by providing that mobility, we can demonstrate too that there's significant developmental benefits. And one webinar I've done in the past for ABLEnet is discussing the importance of early mobility and some of what research has indicated in bringing mobility to our youngest clients. There's huge developmental benefits, and often families might be more willing to explore it because of that. So I hope that helps. Again, big question, great question, but that's just a very, very short answer for now.